Everybody, welcome to our next talk in our Fireside chat series. It is truly my pleasure and honor to introduce James Camarinos. James's preferred name is Cam. He identifies as a white male and he uses the he series pronouns. Cam is a graduate of the Bachelor of Science and Doctoral of Physical Therapy program at Sargent College. After graduation, Cam completed a full fellowship in manual therapy at the Institute of Orthopedic Manual Therapy and is a fellow of the American Academy of Orthopedic Manual Physical Therapy. Cam is the current director of the Boston University Physical Therapy Center. He is faculty at the BU Orthopedic Manual Physical Therapy program and is the lead instructor for the healthcare management course within the Doctoral of Physical Therapy program. He's involved in the care of all injuries and in particular works with the team of BU Physical Therapy Center clinicians to care for patients who have sustained a concussion. Cam, thank you for joining us.
Thank you. That was too long. Thank you.
It's surreal. I've known Cam since he was actually a student in the program and has just grown to be an amazing man, amazing dad, an amazing physical therapist who actually treats my own son. So he's outstanding. So thank you for being here. And so let's just start a little bit with, for those, that aren't intimately knowledgeable about our physical therapy clinic on campus. Can you just talk a little bit about the clinic and the history of the clinic since you've been here?
Yeah, sure. Thank you. So our clinic's been around for a really long time, since the early 90s, but I joined the clinic in 2009. And our clinic is a very unique place. We are an outpatient clinic, no different than most outpatient clinics you would envision in the physical therapy world. But the key difference is we're embedded within the Department of Physical Therapy and Athletic Training. So with that, we have this sort of double-sided mission. We have to be a functioning real-world clinic. And then when in functioning, I mean, the university doesn't give us any money. So we have to run just like every other private practice has to run. So we have all the burdens and all the benefits of that situation, but we have to do it in a way that meets the academic mission of Sargent College. So that includes, delivering care at the level that we expect and delivering care in line with the way it's taught in Sargent, but also, providing opportunities for our clinical students and doing all the things that requires. So it's this interesting clinic in that we're not exactly an academic sort of faculty clinic, but we're also not a full real world clinic. We're sort of something in the middle.
So where is it located? Like, is it in Sargent now? Where's it located?
Yeah, sure.
Footage do we have?
Sorry, I think I'm assuming too much. Is there audio kickback? Is that me into you?
It might be.
Yeah.
I'm not getting any audio kickback.
I am Cam.
Yes, and everybody else is muted, I think. So let's give it another try.
Yeah, sure. Kelly, if you mute, maybe it's you. It might be me speaking into you. Is that better? That seems better. All right.
I'll mute when I'm not talking.
Yeah, so the clinic is physically located right behind FitRec. So if anyone has been to campus recently, the Fitness and Recreation Center is BU's gym. It's right where the Armory used to be many years ago. And the clinic is physically within the building of FitRec, but it's its own separate space. The BU Physical Therapy Center itself is a part of what's called the Ryan Center for Sports Medicine and Rehabilitation. So the Ryan Center exists and is sort of like the housing of the BU Physical Therapy Center, but also it houses athletic training services. It houses physicians from Boston Medical Center in family medicine, sports medicine, orthopedics, neurology, and radiology. It houses the Sargent Choice Nutrition Center. So there's a lot of health professionals all under the roof of the Ryan Center. And the PT clinic is just sort of the biggest part of it from a volume and sort of size standpoint. So we're a part of this big network of professionals where the vision many years ago was to have one place where if you had an injury, you could walk in, get an x-ray, see your physician, walk down the hallway, see a PT, like that. So it's a physical location where ideally a lot of the barriers and red tape of healthcare could hopefully be stripped to some degree. And then because of the fact that it's right where it is in the West Campus, like student health services is next door, the primary care group from BMC is across the street. So it's this nice little sort of central hub of care for a lot of different patients.
So let's talk now about staff. How many PTs are there? What are their credentials? What are their backgrounds?
Yeah, so we have a pretty large staff. So the clinic itself, just to kind of orient size, is the whole space is about 10,000 square feet. So it's pretty large. Right now we have about 11 and a half sort of full-time equivalent clinicians, but there's 18 PTs that directly work in the clinic. That's about the size of, it depends how you think of it, but for most outpatient clinics, that's about 4 maybe outpatient clinics, sort of from an average standpoint. We have 4 full-time front office members. We employ 30 students. So it's a pretty big operation. As far as the staff goes, within those 18 individuals, with the exception of one new grad who is about to start in our upcoming residency program, every single individual that works in that clinic has advanced certification somewhere. So either they are board certified in orthopedics, they're board certified in sports physical therapy, or they're fellows in orthopedic manual physical therapy. So the fellowship Kelly listed in the beginning, we house currently the only accredited fellowship in New England. I received mine from Al, who's on the screen here. Thank you, Al. And within the state of Massachusetts, it depends on when you do this kind of thing, but there's probably 40 to 50 fellows in Massachusetts, and we have somewhere between 8 and 10 in the clinic right now. So we have a lot of very well-trained individuals that treated this clinic, and that is, I think, as we talk about the evolution of the clinic and the growth that's happened, that's right at the center of why that's happened, I believe.
Amazing. Yeah. We have some of the best and brightest minds in Boston, all under one roof. So what about patients? So, I know a lot of people, there was a misconception that the clinic was always just there for faculty and staff and students, but who makes up the patient population at the clinic?
Yeah, it's for many years that was probably closer to true. And as the clinic has grown and evolved and done a better job at various ways of people getting in the door, we see a pretty large population from outside of BU. So the clinic is primarily orthopedics. About 95% of the patients that walk in the door have some kind of a musculoskeletal injury, back pain, knee pain, neck pain, things like that, post-surgical conditions. And then currently, it depends on the year, but anywhere from 4 to 6% of our patients are seeking care after sustaining concussion, which has definitely been a huge growth in the last handful of years. But as far as where they come from, it's kind of everywhere at this point. So it, again, like most things on BU's campus, we ebb and flow with the school semesters, but at any moment in time, if you kind of run it across the year, about 20 to 25% of our patients are BU students. Another 25, maybe 30% are BU faculty and staff. And then the rest is from the community. So it's about 60-40 kind of BU and outside of BU.
So now let's talk about just growth under your leadership. So started off, let's go back to, you started off as a student, and we didn't want to let you go. So can we just talk a little bit about like your trajectory from, doing your last clinical affiliation at the Ryan Center to growing into the position you're in now?
Yeah, sure. I'll briefly talk about me, very briefly, and then more so talk about the clinic. So yeah, I was fortunate to have my rotation, my third rotation in PT school at the clinic. My CI was Sargent Martin, who's now faculty in the department, and I was just really lucky that there was an opening at the time that I finished school, and I was fortunate enough to stick around. So fast forward a few more years, the position of then what was titled the manager, the position opened up, and sort of the same thing. I was at the right place at the right time, and I guess was encouraged to seek this out and took the leap, and that's where I've been ever since. So I was very, very lucky to have, frankly, like just really great people around me and a great staff and everyone that was pulling in the same direction. So I don't view any of what happened in the last, I don't know, 8 years as like me. But I'm just lucky to be a part of it. But yeah, we've grown considerably. So I've been in my position since October 2014, 2013, I'm sorry. And in that time frame, we've grown considerably in every which way you can measure growth. So probably most importantly is we've grown, I believe we've grown in the quality of care that we deliver. You know, we've turned into some people will call it a learning health system, but we're a clinic that built into what we do every single day is constantly improving. We have a lot of ways that we've tried to figure out how to do that. So I'd say that's easily the biggest growth. Our post-professional programs have grown. We house a fellowship. We're about to start a residency in orthopedics next year. Our clinical placements have grown. Our research has grown. And of course, to fuel a lot of that, you know, the operations of the clinic have grown and finances and all that stuff. But I would say the things that really matter for our clinic are the things that, you know, from a quality standpoint, really is what from around 2013 on has really accelerated.
So you've been talking a lot about fellowship programs and orthopedic residency program. I don't think everybody that's with us tonight is familiar with those. So can we maybe start off just talking about what is a fellowship program? What does that mean? How did we start one at BU? And then after that, can we go in and talk about orthopedic residency program, what that means, what that entails, and how you started one?
So again, definitely not I started, but there's a large we. But when people finish PT school, if there's any non-PTs here, you finish PT school and in theory you're done. You don't need to continue on. You don't need to pursue post-professional education. It's not like becoming a physician and you know, you effectively have to do a residency. Where the profession is moving is to encourage more people to do that. And more the typical path these days is for people to finish PT school, pursue a residency sort of in their first year or perhaps 2 years after school, and then pursue a fellowship. And so if you think of it the same way you think of medicine, you know, your fellowship is sort of at the pinnacle, at least of your formal educational training of what you're going to get. And in orthopedics, manual therapy, I would say for many years and to this day is still very much that. It's sort of the highest level of formal training you're going to receive. So back in 2014, we started a fellowship. And so Lee Marinko is the director of the fellowship. Again, she's faculty within the department. And the fellowship sort of lives within the clinic. For a handful of years, we had a collaborative partnership with an external clinic called ProX Physical Therapy. Right now, our fellowship is really actually just BU. So it's just within our clinic. Fellowships are changing and they're evolving. And now fellowships actually have to have a residency to then pursue a fellowship. So we, for many years, have thought that we should house a residency as well. And now that's exactly what we're doing. So we are actually yesterday, I was interviewing for it. We're enrolling our first class of an orthopedic residency in September. So what our hope is, and sort of the vision is that we continue what has happened, which is we are really fortunate to have a long list of students that do their clinical rotations while they're at Sargent with us. And then when they get into their professional career, this is sort of this launching pad where they can come and get formal training at the clinic, pursue orthopedic residency, pursue orthopedic manual physical therapy, and off they go. And you know, hopefully they stay with us, but of course that won't always happen. But I think as the years go on, and as the years have gone on, you know, the fellowship has graduated. I want to say the number is about 65 individuals in the last 8 years. So it's not a small amount of people that have been formally trained at BU. That number is going to shrink a little bit because the program is just smaller now by design. But that's from a post-professional education standpoint, much of what I think has trained our staff and certainly has helped, you know, advance the profession, at least locally.
Fantastic. How many are you hoping to accept into the first program?
So we'll have two. So right now we have 2 fellows in the program, and year in, year out, we'll see exactly how this shakes out from year to year, but the ambition is just to have 2. So we'll have 2 residents, 2 fellows every single year.
Fantastic. Do you find that they tend to be new grads? Are they people that have been out in the profession for years and wanting to come back? Who do you find is applying to our programs?
Yeah, it's a bit of a mix. At least residency is obviously very new, but right now it's a blend of new grads and one and 1 2 year out graduate. Fellowship is a little bit wider. So for the most part, fellowship, you kind of can't do it right out of school. So you have to be at least a year and a half, 2 years out. But one of our current fellow right now, she was 5 years out and came back and did it. So it's usually somewhere in that first 5 6 years of practice where people have the time, logistics, energy, ability to work with no sleep, where they're willing to pursue it. So that's the pretty typical path.
Are you saying when you have kids, you have no energy? No.
Coffee. I have a lot of coffee.
So let's now talk about clinical education at BU. As we know, one of the strengths of our program, our physical therapy program, is our clinical placements. How does BU Physical Therapy Center work hands in hand with the clinical education department at Sargent?
Yeah, very closely. So clinical education placements are a little bit funky because when you're in PT school, the students express their interest to go to a certain place, and that's often dictated on where they're from and where they have housing and things like that. But a lot of the growth that I talked about is sort of the clinic and of the business, if you want to think of it that way, has actually been the best benefit of that is clinical placements. So we went from right around 7 full-time clinicians 6-7 years ago, and then we're now way higher than that. So we've grown by about a third in a really short run of time, and what that's done is it's given us more staff, and with more staff we get more placements. So this past year we had if we blend like last year and this year, we'll have somewhere between 16 and 20 full-time rotations through the clinic, and then we do another 20 to 30 full-time rotations part-time rotations, where 1 day a week DPT students come and do their rotations through the first year. So we have just a large volume of students that are rotating through the clinic, and the growth of the business, like I said, has fueled that. And clinical education is hard. Like clinical education, it's hard to find placements, it's hard to find rotations, and that's something that the clinic ed department struggles with. And so our sort of driving force is to be that resource for them, where not only are we giving them a volume of placements, but we're also giving them a very trusted resource. So they might take a student that has a real keen interest in manual therapy and say, we want them to go with you. And they might take a student that's struggling and say, hey, we really want your eyes on them so that we can make sure they're getting what they need and get through. And that's something we take a lot of pride in. And I think, I know that it's of real benefit to the clinic ed department. So that's, if there's 3 missions of the clinic ed is perhaps the biggest one. Without that, we're really not meeting what Sargent needs, and we take a lot of pride in that.
And then the current staff that work there, are they involved at all in teaching within the physical therapy program?
Yes, they are, very much so. Of the 18 PTs that I mentioned that are at the clinic, 3 are faculty. So Lee Marinko, Diane Dalton, and Lisa Brown are all primary faculty that treated the clinic. And then of the full-time staff of the clinic, myself and Trey Sears and John Raymond and Dan Siskavich, Kaylee O'Brien, Greg Schiller. So 6 also go down the street. So we have this constant back and forth of faculty that are bringing everything that they own in their skill set and in their expertise to the treating clinicians, and then we have treating clinicians that then bring it down the street to the college. So I think for the DPT students, it's really rewarding because like I'm teaching right now in this fine lab, and I can walk into lab and say, hey, we're going to talk about patients that have numbness and tingling down their leg, and here's what I saw 10 minutes ago. So it makes their education very real, and it makes their education something that's not sort of floating in the ivory towers of academia, where they see that we actually do this. We actually treat patients the way we're suggesting that they should. And I think they like that. I hope they like that. Kelly, you would know better than me, but I think they like that.
I personally think they love it, but I think on the flip side too, just maybe talk a little bit about the benefit that brings to patients. For those of you that don't know, in the state of Massachusetts, physical therapists do not have a continuing education requirement. So you could have graduated in 1992 and literally never taken a continuing education class. So do you want to just talk a little bit about how the clinic mission and the academic mission really match together to provide excellence of care?
Yeah, absolutely. And they're hand in hand. So I would say my actual job is to uphold that. Like my real job, and what I tell anyone that wants to come join our staff is that we're going to hold them to delivering care the way we teach it. Simple as that. Sounds pretty simple. But if any of you here are clinicians or have been around clinics, you know, there's this sort of idea that there's what you learn and then there's the real world. And of course, like what you learn has more black and white to it because you're learning it and that's how it's presented. But it doesn't have to be so different. And what we try to do is actually and truly embody exactly what we tell them that they should do. And then it goes both ways. You know, I'll give you a good example. So last year, or not last, a handful of years, but Diane Dalton looked at the practice guidelines for low back pain. It's the second most common people go to the doctor. It's the most expensive musculoskeletal condition in the United States. It's the most pervasive orthopedic injury you could ask for. It's expensive, it's costly. It has a huge driver of the opioid crisis. Low back pain is everywhere. We looked at practice guidelines and said to ourselves, all right, well, for us, sort of the table stakes, bare minimum is you have to treat the way the guidelines suggest. And that's possible. Like that's not that wild of an idea, although it's extremely uncommon. So at minimum, we say we need to do that. But then we said to ourselves, all right, are there holes in this? Are there pieces of the literature that don't answer everything that we need to do? Are there pieces that are gray? And so Diane and us, the collective we, collaborated and started to figure out, all right, where are the gaps? And are there things that we can try to do at the clinic that take what's at the front of the literature, put it into practice, and then study that? And that's exactly what we're doing. So we have a lot of sort of processes like that that are sort of iterative and build on themselves, where we try to look at the literature that the faculty helps drive to the clinic. We bring the experience and the real world sort of nature of the clinic to that and try to see if we can push forward just a little bit. And like, to me, I think the dream of that is that we're this kind of little incubator of sorts where we can really be progressive in what we do. We can do the minimum, which is just treat the way we should be treating, but then really try some innovative delivery models and care processes, and then see and study it and disseminate it. So that's been in the last 3 or 4 years the thing we've really done a lot of. One thing that fuels that significantly is patient outcomes. So people, if anyone's ever been to PT, or if you are a PT, you'll know what a patient-reported outcome is. Outcomes are basically, the easiest way to think of this is the best attempt to objectify how people are doing. So when I first started practicing, we used outcomes a little bit, Kelly, back in the day, but it wasn't a constant thing that was done all the time. And the most typical thing that a patient would say when they walk in the door is, "Hi, how are you doing?" And they're like, "I'm doing great." And you're like, "All right, cool. And let's here we go. Off we go." And what the profession has realized is that that's great, but it's not sufficient, and that we need outcomes to prove our value and our worth. And so our clinic is part of a big national educational collaborative with Intermountain Healthcare, which is a huge health system in Salt Lake City. And we collect patient-reported outcomes, and we all collaborate and put these outcomes into this a software called ROMS. ROMS is one of several things in the PT industry that aggregates patient outcomes. But the power of that is it gives you somewhat of an objective view of how you're actually doing. And at least in terms of healthcare reform and where that's going in the United States, for PTs to try to put themselves at the center of that conversation, you have to show worth and you have to show value. And that's something that has long been preached in academia, but from a sort of policy and an industry standpoint was never really asked. We started doing it because we believed it was the right thing to do. And actually now that is policy. So within the next 3 years, you actually won't get paid for Medicare unless you do these things. So we've been doing that for a long time. And then it's helped fuel a lot of what I'm talking about tonight, which again, it's something that the college and the academic mission pushed that, and now we're embodying it the same way that the profession is being forced to embody it.
So outside of outcome, what research projects are you currently embarking on? I know, I believe it was you and Louise just had a paper published. Can you just talk about, congratulations.
Thank you.
Just talk about current research projects, current publications, what is coming out of BU Physical Therapy Center?
Yeah, thanks. So yeah, Louise and Emma Zelligson, so two of my colleagues, they did, frankly, most of the work. I was just a name on this thing, but we published a case series regarding telehealth. COVID brought us this gift of telehealth, and we decided to look at some cases and how we applied telehealth, and it worked very, very well. So that's something that just came out, and that was in the JOSPT Cases Journal. We have two big research studies happening right now. So the first is one that a randomized control trial is being developed, but we're part of this thing called the BACPAC consortium. BACPAC is a multi-site, multi-institution collaboration of a lot of different places across the country. The whole initiative has about $140 million of NIH money behind it. We're not all of that, but we're a part of it. But we're going to be studying a technology called a soft exosuit. Ironically, the sort of whole research consortium is called the backpack. This thing is actually a backpack. So it's a piece of technology that you wear, and it's designed to try to offload some of the forces that go through the lumbar spine. So we're sort of the technology arm of that trial, and we have two clinicians plus Diane Dalton who are doing that. We have another big grant-funded trial that's called WeSense. This is one that's looking at the effect of physical therapy and sort of contemporary physical therapy for individuals with knee osteoarthritis, and then also tracking them with wearable sensors. So from an outcome standpoint, not just relying on the words that they tell you in a questionnaire, but when you actually track their movement through something like a wearable sensor, is that valid? Is it reliable? And actually, does it measure change? So those are the two big grant-funded studies that are happening right now. That'll happen for the next, WeSense is stopping this summer. The other one's going to go for another 3 or 4 years. So those are two big ones. And then we've had a lot of other collaborative projects that some we've driven and some the college has driven. Lee Marinko and I are right now working through a publication process, assessing what does it mean for patients that come to our clinic and don't pay anything out of pocket compared to those that do. And if you're on the BU Health plan, you don't pay any money if you come to our clinic. Kelly, thank you. And we're trying to look at the influence of that. Deductibles, I'm sure most of you have a deductible because almost everyone in America has a deductible, have skyrocketed in the last 10 years. And so we're trying to see when you strip that away, what happens. So we're working on publication for that right now. I'm part of a collaborative research project with Mary Beth Holmes, who again is faculty at Sargent, on what's called common factors and how they influence patient outcomes. So irregardless of things like how I stretch your knee or how I prescribe exercise, how much empathy is expressed, how much alliance or how good of a relationship between patient and therapist, how much validation occurs. They're called the common factors in the psychotherapy literature. That's starting to get studied in the PT literature, and Mary Beth is right at the front of it, and so we're doing that at the clinic. The last one that's happening right now is a collaboration with Kara Lewis. So again, Kara is faculty at Sargent, at looking at when can you digitally measure movement and then assess when people change through therapy, if that's a reliable way to do it. So she's trying to sort of a technology capture to see, can you capture change in movement connected to change in outcome? There's a lot of studies that all actually, again, this is a little bit of the gift of COVID. Research in a real world clinic is hard to do unless you have a big grant funded trial that's sort of occupying time. Most of your day is spent on scheduling patient care. And so COVID had this sort of mandatory pause for us that let a lot of these research trials really accelerate. And now they're just part of the fabric of what we do.
Amazing. I can't wait to see the outcome of, cost sharing versus no cost sharing. I mean, some of us remember the day, maybe when you were younger, where you just went to the doctor and you didn't have a copay, or you didn't have coinsurance, and you didn't have
Yep.
deductible. And, now you have a patient come in that has an $8,000 deductible, and they tell you they can only afford to see you 3 times.
Yeah.
So really looking forward to reading that when you publish it. So thinking to the future, what are some of your short-term visions for the clinic?
Yeah, I'd say we have a few short-term ones. The short and the long, I think, kind of feed each other. But first and foremost, we're sort of still on the tail end of this lovely pandemic. So we right now, actually, literally in January, got ourselves back to the staffing level that we were at pre-COVID. So like everyone, the operation of the clinic shrunk. We retained actually all of our staff. We had some natural attrition by people leaving and moving, but we continued the operation of the clinic and the staffing of the clinic, which we were really proud of. But we're right now just back to sort of normal flow. So more short term is, we got to sort of get back to the normal way of things. Outcomes are far and away, I'd say, the most immediate thing that we're working on. There's reform through Medicare with how we're reimbursed. And so the blend of the patient-reported outcomes we collect and how the profession is changing in terms of the way PTs are reimbursed is probably the most immediate sort of opportunity and challenge that we have ahead of us. I'd say between that and all the research trials, that's occupying a lot of our sort of immediate focus. But I think the long run view of the clinic is a little bit of what I was alluding to earlier, which is to look at the idea of quality improvement and really incubate some innovative ways to deliver care, whether that's a unique way of treating low back pain, and I think something we really have ambitions of doing is figuring out how to put PT way more at the center of orthopedic healthcare. So direct access is the idea that a physical therapist can be the first point of contact for a patient. That's something that's legal to some degree in most of the United States. It's something that's been legal in Massachusetts for a very long time, but our clinic actually never was sort of allowed to do it because of some licensure reasons, but we now are. And so since COVID, again, another little gift, about a third of the people that walk in our doors come in straight to us. And that's provided some real opportunities, I think, within the university to try to figure out how can we become more of sort of central part of delivering care in a really high level and efficient way. And there's a lot of evidence around that idea that I think our clinic is very poised to sort of really embody. So that I think is when we look at this idea of cost sharing and this idea of quick access to care and care that is conservative in nature and not giving you an MRI and not giving you an injection and not giving you opioids, that's something that physical therapists, that's what we do. We don't do any of those things, and we do deliver high quality care. So I think putting ourselves a little bit more at the center of care at the university and certainly in our community is something that is probably our blended short and slightly longer term ambitions.
So just one other quick question for you, and then I can't wait to open it up to everybody, just question and answer, things that I didn't touch base on that you would like to ask Cam. I know a lot of us during COVID had the experience of telehealth. And I know that you seamlessly and all of the clinicians pivoted to telehealth to continue to see your current patients. Is that something you're continuing forward? What are your thoughts on telehealth, and is BUPT still offering it? And what were some of the reactions of patients?
Yeah, so we are still offering it. The reaction was amazing. So we were forced to physically close for a period of time when COVID hit. And I will never forget that we, on a Sunday, made that decision, and on Monday saw our first patient in telehealth. So we booted sort of this whole entire operation of something we've never done before in 24 hours, which is just a testament to the staff that we have and how skilled they are. The patient response was incredible. So our patients pretty immediately jumped in to do it. And I think what everyone saw is that telehealth, it's not perfect. It can't replace what in-person care delivers. But it does capitalize on probably the thing that PTs do best, which is we form really meaningful relationships with our patients. We educate them about what's happening, and we get them active. And you could do that through this medium. And I think that was something that we saw that was really well received, and largely what the hope is that continues. There's a huge sort of legislative fight around if telehealth is going to stay. It looks like it will. A lot of private payers are actually more quickly advancing and doing it. Medicare has been the one slow one, but Medicare requires a full act of Congress, literal act of Congress, for telehealth to become permanent. So, we'll see how that goes. But we're hopeful. I think as a profession, we're hopeful. So, I mean, if that all sticks, I think telehealth is here to stay. And I think what it'll do is it'll never replace in-person care, but I think it augments it. I think it gives you opportunities to perhaps see patients a little bit quicker, because you can see them immediately at the point of them contacting the clinic. You remove massive schedule burden sort of on all sides of the coin of what it takes to get a patient to show up in your door and what it takes for you to free up your schedule to see that patient. So I think on the front end of care, it gives a lot of opportunities. And I think on the back end as well, like it's not uncommon that patients stop care too soon. That's a very common theme in physical therapy. And I think what telehealth perhaps does is it gives a very easy and convenient and low stakes way to 2 months, 3 months, 4 months down the line, just touch base and see how people are doing and make sure they're advancing the way they want to. And that's how I think as it's gone on, early on, telehealth kind of replaced everything because it had to. As it's gone on, I think that's what we've seen as the value is it gives people a lot of convenience of both being seen quicker and a little bit being seen through their care. I suspect that's how it'll probably shake out.
Yeah, so many wonderful things. Just, when a patient would come in and say, I have pain sitting in my dining room chair, you can now see them sitting in their dining room chair, getting my clothes out of my dryer, and you can now see them doing that actual task and really do, an analysis of their movement to help them best. So fingers are crossed, that with our social medicine system of Medicare, that they will allow that going forward. So I now want to open this up to everybody, just questions that you have about, physical therapy, about our amazing clinic on campus, the academic mission of it, the clinical education mission of it. You're either welcome to unmute yourself. The chat is open. Raise your hand.
Al, go ahead.
I'm interested about the third of the patients that you have that are direct access. Our payer mix is such, there's a lot of gatekeepers. So the direct access, of course, has been legal for many years, but the insurance coverage is the other issue. So how do you have so many of those?
Yeah, probably the biggest reason is our Medicare mix is quite low. So only 5 or 6% of our patients are covered by Medicare. And that's probably that's the biggest gatekeeper of this kind of a thing. The BU health plan, which BU offers 2 health plans to all their faculty and staff, most have a PPO and there's no gatekeeper.
Gotcha.
So you blend that with sort of a variety of PPOs that are sort of around there anyway. I'd say our patient mix allows that larger percentage. When we look a little bit deeper, that third number, a lot of those people are known to us. So that's definitely helped. We have a sort of a captive audience, both in terms of, how they enjoy receiving care at the clinic and location and sort of all the convenience that the clinic, I think, offers if you're in and around the university. So that's been not a small piece of why that number is so large.
Yeah, I mean, building those relationships, you're going to have that. I was just curious from the administrative part of the payer, right? As you guys were talking before, interesting to see what happens when it comes out of your pocket versus not. And, that type of access with that. So thank you, sir. I'm very proud of you to see where you've gone. This is good stuff.
Thank you, sir.
You're welcome.
I owe much of it to the training that you and the whole crew gave. So thank you.
I think a lot of it's on you. Nice job. Thanks.
Other questions? I'll wait just a minute to see if anything comes in the chat. Okay, Cam, I know how you've worked all day, came home, took care of 2 kids. Thank you so much for giving us your time, for being such a leader, amazing clinician, and part of our alumni association. We're so fortunate to have you. And thank you everybody for joining us. Our next fireside chat will be the first week of April on April 6th. And we have a panel of 4 current students, 1 human physiology, 1 health sciences, 1 student in the doctoral physical therapy program, and 1 occupational therapy student. They are going to be talking about a day in the life of a Sargent student. So we remember what our days looked like, but now what does a day look like now? So we're going to have an amazing panel of 4 students. So I hope you can join us on April 6th. I hope you have a wonderful night. If you're here in Boston, please be safe if you're driving. It's snowing. For those of you that are in warmer weather, we are jealous because it's in March and we're getting a nice snowstorm. So I hope everybody stays well. I look forward to seeing you in April. And Cam, thank you so much for being with us.